Dr. William B. Grant has a PhD in physics from the University of California, Berkeley. He had a 30-year career in atmospheric sciences before turning to health research in 1996, using an ecological approach to link dietary factors to the risk of Alzheimer's disease, resulting in the first paper linking the two. Building on the work of the brothers Cedric and Frank Garland, he used NASA satellite data for solar UVB doses in 1992 in ecological studies to show that 13 types of cancer, which was 8 more than previously identified, had mortality rates inversely correlated with UVB doses. After retirement from NASA in 2004, he moved to San Francisco and formed the nonprofit organization Sunlight Nutrition and Health Research Center. Dr. Grant has published several additional ecological studies related to UVB, vitamin D, and dietary factors, among others. He has also carefully examined how observational studies and randomized clinical trials are conducted regarding vitamin D, resulting in several publications pointing out the limitations of such studies and how they can be improved.
My topic for this presentation is the roles of vitamin D in cancer risk reduction and brain health. In disclosure, I have received funding from Biotech Pharmacal, Inc. in Fayetteville, Arkansas. It is a supplier of high-quality vitamin D and other supplements. Let's set the stage regarding cancer statistics in the United States for 2024. The number of estimated new cancer cases is 2 million. Number of estimated cancer deaths is 610,000. Estimated melanoma cases, 100,000, but estimated melanoma deaths is only 8.3 thousand. Melanoma to cancer cases is around 5%, but melanoma to cancer deaths is 1.4%. Melanoma to all deaths is about 0.3%. So there are several types of studies used to determine risk of cancer. There are geographical ecological studies. These are observational studies in which populations are defined by geographic location, and values for health outcomes and risk-modifying factors are averaged for each population. There are traditional observational studies. These are usually prospective cohort studies, and I'll discuss the details later. There are randomized controlled trials, RCTs, and studies of mechanisms. Cedric and Frank Garland, the brothers, get the credit for proposing that vitamin D reduces the risk of cancer. They were beginning graduate students at the Johns Hopkins School of Public Health in 1974, when in the first week of attendance, they were called in for a seminar by a representative from the National Cancer Institute showing maps of cancer mortality rates for the United States for the period 1950-1969. Now, Cedric and Frank had just driven from San Diego to Annapolis. They knew it was very sunny in the Southwest, not very sunny in the Northeast. And they sort of, colon cancer had a map, which I'll show in a second, that piqued their curiosity. And they figure that it's got to be sunlight. So here's what they saw on the left. This is colon cancer mortality rates by county, so large intestine or colon. The reddish or rust color areas in the Northeast are higher rates. White in the Southwest and the South are lower rates. And on the right, you see contours of annual sunlight below 350 units in the Northeast, over 500 units in the Southwest. And you also see some scatter plots of mortality rates versus solar radiation. And so they figured this out in 1974. They submitted their findings to several medical journals for several years. It wasn't until 1980 that this work was accepted in a British journal, the Epidemiology. That was because the mainstream journals just didn't want to promote vitamin D for reducing risk of cancer. The mainstream medical journals are part of the advertising arm for Big Pharma, and they want to promote drugs. They want to promote surgery. They want to promote medical care. They don't really want to prevent disease. And so that's why it took a long time for this to be accepted in a journal. Now, in 1999, the Atlas of Cancer Mortality Rates in the United States from 1950 to 1994 is published, and I got a hold of the copy. And an example of what they showed was the colon cancer for white males on the right-hand screen. The red areas show the highest mortality rates. The blue ones, dark blue, show the lowest mortality rates. Now, at that time, I worked for NASA Langley Research Center in Hampton, Virginia, and I was aware of the measurements of solar UVB dose of the Earth's surface by the total ozone mapping spectrometer. And here is, on the left is the map of the UVB at the surface for July 1992. What you notice is it's very asymmetrical. The highest rate is in the southwest, Arizona, New Mexico. Lowest rate is up in the northeast. The reason for this asymmetrical pattern is that the western half of the United States, from the Rocky Mountains to the west, has very high surface elevation compared to the east, which has very low surface elevation. So the atmosphere scatters radiation and attenuates the amount of UVB reaching the surface. Also, as the prevailing westerly winds try to cross the Rocky Mountains, they push the tropopause higher, making the stratospheric ozone layer thinner, which again reduces the attenuation of solar UVB radiation. So I spent a couple of years correlating the values for the solar UVB dose map to the state economic areas shown like in colon cancer on the right. Here's what we see, what they showed for breast cancer rates for white females. Now you notice it's very similar to that for colon cancer, except on the West Coast. So solar UVB had a little bit less benefit for breast cancer than for colon cancer for males, in part because women spend less time in the sun than males. But also you notice along the coast, the rates are a little bit higher than they are, say, inland. That's because the coast has more fog and clouds. San Francisco, for example, is very, very foggy in the summer, but very, very similar patterns otherwise. It turns out that this Atlas of Cancer Mortality in the U.S. is now available on the web. Anybody can download it. You can see all the cancer maps for males, for females, for African Americans, and whites. And it's a very, very useful reference. So in 2002, I published a paper with my findings in the Journal of Cancer, a mainstream journal. I confirmed the findings by the Garlands and colleagues for breast, colon, and ovarian cancer, and for prostate cancer, non-Hodgkin's lymphoma by others. I added 8 types of cancer: bladder, esophageal, kidney, lung, pancreatic, rectal, stomach, and corpus uteri. And here's an example of the correlation I found. This shows for the mortality rate for colon cancer, for breast cancer for white females for 1970, 1994 versus the solar UVB from TOMS. And notice that there's about almost a 30% reduction in cancer mortality rate for the highest solar UVB doses, say for Arizona, New Mexico, and part of Texas, compared to what there is in the Northeast. Now, it turns out that once this was published, the critics said, hey, wait a minute, you didn't do the study the way it's normally done. which is to include also the other main cancer risk modifying factors called the comorbid factors. So I put them in. I put in alcohol consumption, Hispanic heritage, lung cancer, poverty, and degree of urban residence, and redid it, sent it to 9 mainstream journals over a period of 4 years. Again, they all reviewed it, said, well, gee, we don't want to publish it, sorry. Finally, it was accepted as a conference proceedings paper for a conference held in Germany regarding UV and vitamin D, published in a Greek journal, Anti-Cancer Research, in 2006, and has Cedric Garland on as a co-author. It now has over 250 citations, so it's well accepted. It turns out the effects for cancer and UVB were essentially unchanged. I did add 2 cancers, but I showed the effects for alcohol consumption, Hispanic heritage, smoking, urban residence, and poverty that agreed well with the literature. But again, you know, the mainstream journals, as the advertising arm of Big Pharma, just didn't want to go there. Now, what happened? How did the cancer rates change, and how did the risk modifying factors change from 1950 to 2020? Well, first of all, people gradually spent less time in the sun, gradually increased sun protection, gradually increased obese rates, and cancer treatment became much more advanced. Thus, the UVB vitamin D effect, which was already apparent in the cancer mortality data up to 1994, was no longer quite as apparent. And I'll show this in the next. Okay. Meanwhile, let's see. It turns out melanoma rates have increased because of sunscreen use. And in fact, Cedric and his brother Frank and Ed Gorham were the ones who pointed this out. When the sunscreen manufacturers wanted to find a transparent sunscreen instead of the zinc oxide, which is white and makes people look funny, they used compounds that are transparent in the UV. Turns out they block the radiation that causes erythema or reddening, but it also blocks the UVB production. But it doesn't block UVA, the long wave UV. It turns out that UVA, being longer wavelength, penetrates deeply into the skin, and that gets down to the melanocytes and causes mutations in the melanocytes and causes melanoma. So if you block the UVB, you're not providing the vitamin D that fights cancers, including melanoma, but you're increasing exposure to the UVA, which causes melanoma. And so the melanoma rates have gradually increased by at least a factor of 2 from 1990 to 2015, thanks to wearing a sunscreen that does not block UVA. Now in Europe, sunscreen, the transparent sunscreen, does include more chemicals, more compounds that block UVA, but our Food and Drug Administration has considered that these compounds may be toxic to humans, and so they haven't permitted these compounds to be used in sunscreens sold in the United States. So here's what's happened. For colon and rectum cancer in 2016 and 2020, you see the pattern is much different than it used to be. The rates are very high in the South. That's because the Southern diet has a lot of fried foods. Fried foods cause cancer. They also increase obesity. Smoking rates are higher in the South, and air pollution is very high in the South. You also have dark blue up around from Nebraska through West Virginia. So you've got a whole different distribution here. For breast cancer, you have sort of the same pattern as you had in 1970, 1994, with the highest rates again in the Northeast, lowest rates in the Southwest, but you have other distributions as well. There is an interactive map that anyone can download at gis.cancer.gov, canceranalyst.app. And you can actually go there, you can look at different cancers, different races, et cetera, et cetera. If you're into looking at that sort of thing, I recommend you go there. So it turns out that obesity now is replacing solar UVB as the most important determinant of cancer rates for several types of cancer in the US, and also showing in France in this period, actually in this period for the United States, from 2007 to 2016 for France. So how does obesity increase cancer risk? It increases inflammation, both systemic and local, and oxidative stress. And inflammation increases the risk of cancer. It increases sex hormone biosynthesis and pathways. It increases angiogenesis around tumors. Tumors need to have a good blood supply to bring the nutrients that it uses for growth. And it promotes the epithelial to mesenchymal transition, permitting metastasis, and it lowers serum 25-hydroxyvitamin D concentration. Thus, obesity makes it much more difficult for vitamin D to reduce the risk of cancer. So now going to the traditional observational studies, the prospective cohort studies. Here are the steps involved in conducting prospective cohort studies. First of all, you enroll participants. You send out an announcement to a university and say, please supply us participants to take part in these prospective studies. Then they call in the participants, they measure their factors such as serum 25-hydroxyvitamin D, BMI, maybe dietary factors, and disease, comorbid disease, and so on. Then they enroll these participants and follow them for several years, noticing the health outcomes over time, but they don't update, they do not generally update the values for the factors such as 25-hydroxyvitamin D. Unfortunately, for such cohort studies, the values of factors such as 25-hydroxyvitamin D concentration change over time. As a result, such cohort studies underestimate the benefit of vitamin D, as well as they underestimate the risk due to diets such as meat. So here's an example from Figure 1 in a paper with Alberto Munoz, myself, published in Open Access in March of 2022. What we've plotted here is the odds ratio for colorectal cancer for men as a function of median years to diagnosis from 1 to 13 years. So the upper line is for males. So males spend more time in the sun due to occupation, just like they like to be out and play sports and so on, and are probably less likely to wear sunscreen. Women spend less time in the sun, and cosmetics now have a lot of sunblock in them. So their effect changed very little. But you notice that if you go to extrapolate to zero time, there was a 26% reduction of high versus low for colorectal cancer for males, and a 23% for females. And this is generally overlooked. And so if the ordinary analysis of observational studies can underestimate by factor two the effect of vitamin D. Now, there are a number of meta-analyses of observational studies of the risk of individual cancer sites related to vitamin D intake. So we have results for breast, colorectal cancer, head and neck cancer, lung cancer, renal or kidney cancer, overall cancer death. And these are all showing beneficial effects But like I say, the effects are probably underestimated, perhaps by a factor of 2. Now we turn to randomized controlled trials. Now, for pharmaceutical drugs, which have been done since for the last 20 or 30 years, participants are randomized to receive the drug or a placebo. Health outcomes are reported. Risk is determined by comparing outcomes for those treated versus those given a placebo. Note well, a drug trial would not include participants already taking a drug. Suppose a drug manufacturer was to investigate the results of a new statin. Would they enroll participants already taking a statin? Hell no. They would take naive statin takers. They want to compare taking their statin, to somebody taking no statin. However, most vitamin D RCTs ignore the rules that the drug manufacturers use. They enroll people no matter how much vitamin D they have. They then give too little vitamin D. Most people who would volunteer are educated, high-income people who are quite willing to participate over a 5-year study, taking vitamin D or taking placebo. And then they analyze results according to, do they take vitamin D or not, according to the protocol. Now, Robert Heaney, who worked closely with Grassroots Health, published the guidelines for clinical trials for nutrients in 2004. His guidelines, as adapted for vitamin D, are, first of all, a measure 25-hydroxyvitamin D concentrations and only include participants with low values. Dose with sufficient vitamin D3 to raise 25-hydroxyvitamin to achieve health benefits or improvements. Measure achieved 25-hydroxyvitamin D after a year or 2 and determine health outcomes. Then analyze the outcomes with respect to achieved 25-hydroxyvitamin D concentrations, not vitamin D doses. Hardly anyone does this. There's one study from Iran where they just compared 2 groups of pregnant women, 900 in each case, one in a hospital where they were not treated and have average 25-hydroxyvitamin, 11 nanograms per milliliter. The other, they treated them to raise their 25-hydroxyvitamin to over 20 nanograms per milliliter. They found very significant reductions in preeclampsia, gestational diabetes, and preterm delivery. But you couldn't even do that study in the United States. First of all, very few people have such low values, and even if they were included in a randomized controlled trial, ethically, it's not considered ethically to not give those in the placebo group at least 400 IU per day. So you're not going to confirm this in the United States. So look at the VITAL study. This was a trial conducted at Harvard University with over 25,000 participants, including even 5,000 African Americans. Half received 2,000 IU per day of vitamin D3, and half placebo, for a median of 5.3 years. The mean baseline 25-hydroxyvitamin D for those providing values in the vitamin D treatment arm was 31 nanograms per milliliter. All participants were proceeded to take up to 600, 800 IU per day, as well as spend time in the sun and eat whatever they liked. It was published in New England Journal of Medicine in 2019. For the entire group, there was a significant 25% reduction in all cancer mortality rate, but no significant effect on cancer incidence. However, for those with BMI less than 25 kilograms per meter squared, there was non-obese, there was a significant 25% reduction in cancer incidence. For African Americans who had significant lower 25-hydroxyvitamin D concentration at baseline, there was a barely non-significant 25 reduction in cancer incidence. The abstract, which is what most physicians read, did not mention these beneficial results. nor did Joanne Manson in all the news conferences, all the published reporting, did not mention them. As I mentioned, this is published in New England Journal and advertised in Big Pharma. It limits abstracts to one outcome per study. So it's not gonna promote vitamin D. No siree, Bob. Now here's a result from published by Grassroots Health, organized by Carol Bagley et al. And what it shows is cancer incidence. It's an observational study based on vitamin D supplementation. So they took results from participants in the Joanne Lappy, Robert Heaney randomized controls trials at Creighton University in Nebraska. People were given, in treatment arm, given 1,000 IU per day or so of vitamin D and about 1,000 milligrams of calcium for several years. The mean BMI in those people was 31 kilograms per meter squared. But now when they're analyzed in terms of, and it showed a modest reduction in cancer incidence for those taking vitamin D plus calcium. But they point out that in the calcium arm, the reduction is not significant. So that's for up to about 40 nanograms per milliliter. Now, those in the 40 to 70 nanogram per milliliter range were from the Grassroots Health volunteer observational cohort. They had a BMI of about 23 on average. Now, and that BMI was not analyzed in these findings, but you do see that those who got up to 70, greater than 70 nanograms per milliliter, you had 2 cases of cancer. You had a much lower relative risk of breast cancer than you had for those, say, less than 20 nanograms per milliliter. So this suggests that raising 25-hydroxyvitamin D to above 70 nanograms per milliliter will greatly reduce the risk of cancer. Unfortunately, it's not really a randomized controlled trial, which is what the medical system wants to see. But if you want to go on based on what seems reasonable, based on this and the ecological studies and the mechanisms, you might want to take high dose vitamin D and keep your vitamin D levels high. And you can also enroll in the Grassroots Health volunteer cohort study. You'll want to take your vitamin D level every 6 months and report your health outcomes. I recommend that. So we have a new finding from last year, a very interesting finding from Japan. Now they studied the relapse and death in a p53 immunoreactive subgroup with digestive tract cancer. Now the p53 gene is a tumor suppressor gene that produces a protein that regulates cell division and cell death. When working properly, this p53 protein helps prevent cancer by dissecting damaged DNA and signaling cells to repair it. Well, it turns out if you have this p53 immunoreactive subgroup, you're going to greatly increase your risk of cancer death for gastrointestinal cancers, breast cancer, lung cancer, and some other types of cancer. But they just concentrated on gastrointestinal cancer. So you see on the left-hand side, those given vitamin D had a 20% over a 7-year period cumulative hazard rate of relapse or death, whereas those in the placebo, almost all of them died. If you looked at those, anyway, this is a very, very strong finding. The group in Japan is now applying this to several other types of cancer, but it'll be several years before they get this. What this means, if you develop cancer, you might want to ask your oncologist to measure your p53 immunoreactive properties. And if it's immunoreactive, you definitely want to use vitamin D supplementation. I would say is your main avenue of treatment. But look into this. It's very, very important. Okay, how does vitamin D reduce the risk of cancer, incidence, progression, and metastasis? So vitamin D reduces cancer incidence by mechanisms such as surveilling cells and allowing good ones to differentiate and proliferate, but causes cancer-forming cells to disintegrate, called apoptosis. Just put their compound back into the body. Vitamin D reduces progression of cancer by reducing angiogenesis around tumors. Tumors need blood vessels to bring nutrients to them, and so they are cancer cells, cancer tumors are promoting angiogenesis. Vitamin D reduces angiogenesis. Vitamin D reduces risk of death by limiting metastasis into surrounding tissues. It turns out that vitamin D produces stronger protection against cancer death than against cancer incidence. Remember, the VITAL study did not find that for all participants that vitamin D reduced cancer incidence, but it did find a 25% reduction of all-cause mortality rate by 2,000 IU per day vitamin D production. Our paper in 2002 goes into many, many details of how vitamin D reduces cancer. Turning now to brain health, we're going to talk about cognitive impairment, vascular dementia, Alzheimer's disease, and stroke. According to strokeinfo.org, in 2023, the United States experiences about almost 800,000 strokes each year. According to the Alzheimer's Association, an estimated 6.9 million Americans aged 65 and older are living with Alzheimer's in 2024. This may include those with vascular dementia as well. It turns out about 2/3 of dementia in the United States is due to Alzheimer's, 1/3 is due to vascular dementia, Lewy body disease, Parkinson's disease, etc. But Alzheimer's is the main one. And in my book and my research, it turns out that the three main factors for Alzheimer's risk are eating a lot of meat, eating a lot of ultra-processed foods, and becoming obese. So those are your risk factors. Vitamin D is one of your main risk reduction factors, as well as eating foods that have a lot of antioxidants, green leafy vegetables, et cetera, et cetera. That's another paper, but I've published on that as well. So what I've done recently is I've investigated the role of vitamin D in reducing the risk of all these brain health problems. And it turns out, as mentioned, for cancers, observational studies provide the best evidence. Again, most of these are prospective cohort studies over a long period of time, and researchers not realize that you've got to adjust the findings for the follow-up period. So I've submitted a manuscript to Nutrients on this finding, and here I took the data from Zhang et al. Published this year, and I've gone through and looked at the studies and pulled out those with a medium follow-up studies, follow-up less than about 14 years. So for cognitive impairment, if you go to about a 5-year follow-up, you find about a 70% reduction in cognitive impairment, whereas if you go to around 13 years, you do not find any reduction in cognitive impairment. If you go to overall dementia, you find over a little over a factor of 2 at 5 years compared to nothing at 13 years. I say here it's not clear how quickly vitamin D improves brain health. However, it appears as much quicker than the effects of diet that reduce brain health. It's now thought that you develop Alzheimer's disease over a period of maybe 6 to 8 or 10 years with a bad diet as you get older. But it appears, I think it's much shorter for things like vitamin D. And here's for Alzheimer's disease, again, a factor of 2 for short period, nothing for. And again, this is, if you were to analyze the results, not accounting for a follow-up period, you're going to find about maybe a 30 to 40% reduction instead of a factor 2 reduction. Here, for example, is a meta-analysis, a traditional meta-analysis regarding 25-hydroxyvitamin from prospective cohort studies. So as pointed at the bottom line, the overall odds ratio, risk ratio is 0.78. That was a 22% reduced risk. But you look here, the Judd et al. Study from the United States only had a 3-year median follow-up, and they had an odds ratio of 0.54. Whereas the Scabia et al. Study from the Netherlands had a 10-year follow-up, and they found an odds ratio of 1.13. I haven't yet done the analysis with respect to follow-up time in detail, but I'm pretty sure it's going to be very similar to what I find for the others. And I'll probably include that in the revised manuscript now review at nutrients. So there are function mechanisms to explain how vitamin D reduces the risk of, for example, cognitive function. Here's a study from China. They took people with mild cognitive impairment. They gave them 800 IU per day for 1 year. They gave some of them that, and some of them not. This amount of vitamin D raised 25-hydroxyvitamin from 19 to 23.4 nanograms per milliliter on average. This increased the telomere length from 1.42 to 1.60 and reduced measures of oxidative stress. The telomere length, the telomere is the cap on the end of chromosomes. And as the telomere length decreases with age, as the chromosomes are reproduced and copied, they sort of shave off some telomere. The Nobel Prize was awarded to a woman from San Francisco 10, 15 years ago for pointing out how important that is for aging and so on. But anyway, it's you want to have a long telomere length, and vitamin D has been shown to increase telomere length. So what they found also that IQ increased by 5 points compared to placebo. Results for other tests were mixed. 5 improved, 5 were unchanged, and 1 decreased. So on average, they found increases. There are probably other effects, but this is just one example of mechanisms. So how much vitamin D should you take, and what do you want your vitamin D to be? We published a paper this year saying that in general, to reduce your risk of having vitamin D deficiency, in other words, less than 20 nanograms per milliliter, 2,000 IU per day, or 15 micrograms, is adequate for the general population. That will generally increase levels to above 30 nanograms per milliliter. And according to large vitamin D RCTs, there are no significant safety concerns in supplementing with such a dose for several years, even with individuals with already sufficient vitamin D. And we say this is a simple, effective, and safe dosage to prevent and treat vitamin D deficiency in the general population. However, we also did in 2022 a review of the evidence for increasing 25-hydroxyvitamin for optimal health. And what we said based on observational studies rather than RCTs, the general finding is an optimal 25 reductive vitamin D concentration to support health and well-being is well above 30 nanograms per milliliter for cardiovascular disease and all-cause mortality rate. And the thresholds for other diseases appear to be in the range of 40 to 50 nanograms per milliliter. And this is consistent more or less with what Grassroots Health recommends, if not higher. And the most efficient way to achieve these concentrations is through vitamin D supplementation. If you go to into the sun to try to increase concentrations, there are mechanisms where increased exposure, longer exposure, actually destroys some of the other vitamin D metabolites, and it sort of caps vitamin D levels at around 30 to 40 nanograms per milliliter. So for further information, I recommend scholar.google.com as the best place to find the journal publications. It shows you how many and which papers are cited in any paper. It shows you the papers sort of in order of importance. It shows you where to find an open access copy. The standard place is PubMed.gov. It's the mainstream is operated by the National Institutes of Health. Henry Lahore operates vitamindwiki.com. He spends 10 hours a day sucking in all the latest vitamin D and related information and posting a lot at his website. Of course, there's grassrootshealth.net, which is a very, very good source. And you can reach me at wbgrant@infyonline.net. Thank you for attention. And I hope that you can incorporate vitamin D in your maintaining health routine. Thank you very much.